Hello everyone, this is Santhosh from Assistant Professor cum Respiratory Therapist from the unit of Respiratory Therapy, Yenepoya School of Allied Health Sciences. So today we are going to see about bronchoscopy. So at the end of this session, attendees will be able to identify flexible and rigid bronchoscope, list the parts of bronchoscope, explain the principle and how a flexible bronchoscope works, discuss the indications and contraindications for bronchoscopy, list the complication associated with bronchoscopy. In definition, bronchoscopy is a device used for a diagnostic and therapeutic purpose that visualizes the interior of the airway. It involves the insertion of a bronchoscope through the nose or a mouth by the throat into the lungs. Bronchoscope is inserted into the airway usually through the nose or mouth or occasionally through a tracheostomy. This allows the practitioner to examine the patient's airway for any abnormalities such as foreign body, bleeding, tumors or inflammations. Specimens may be taken from inside the lungs. The construction of bronchoscopy ranges from rigid metal tube with attached lighting devices to flexible optical fiber instrument with a real-time video equipment. Types of bronchoscope. We are having two types of bronchoscope. So first one will be a rigid bronchoscope and second one will be a flexible fiber optic and video bronchoscope. In the images shown, you can easily identify that the wires are connected and it is flexibly bending. So it's known as a flexible bronchoscope, and the one more is made of steel and the straight and rigid type. So it one is also known as a rigid bronchoscope. The rigid bronchoscope made of a straight and stainless steel and rigid tube that provides a larger channel for therapeutic intervention such as removing a foreign body and controlling a significant bleeding. Indications for a rigid bronchoscope: removal of larger foreign bodies, management of significant hemoptysis, debulking or resection of larger endobronchial tumors, dilation of tracheobronchial stenosis, stent placement in the tracheal bronchial trees, managing airway obstruction into the tumors or other masses. This is a typical head and neck position for inserting a rigid bronchoscope into align the mouth, larynx and trachea. Advantages. So, wide channel through which large biopsies and foreign bodies can be more easily grasped or removed. So, airway patency is maintained. It is optimal for a pediatric patients and direct visualization. Disadvantages like the quality of being easily to move and direct is less. Requirement of an anesthetic. So, this may not be suitable for patients with severe tremors and cervical spine instability or certain anatomical variations. Along with that, airway trauma. So, the rigid bronchoscope does not have a longer end. It will be stops in larger airways. So, that will be a limited reach will be there in a rigid bronchoscope. Whereas in the longer recovery time post procedure compares to flexible bronchoscope due to the use of general anesthesia and the invasiveness of the procedure. Now we are going to say about the fiber optic bronchoscope. In a fiber optic bronchoscope, it is made in a thin and flexible tube and it can easily reaches further into the smaller airways, often used for a diagnostic purpose such as obtaining biopsies or bronchoalveolar lavage. Using a Bowden's cable connected to a lever at the handpiece, the instrument's tip can be oriented, allowing the practitioner to navigate the instrument into the individual lobes or segment bronchi. So, most flexible bronchoscope also includes a channel for suctioning or instrumentation, but these are significantly smaller than those in a rigid bronchoscope. Now we can able to see the two images. On my left, you can able to see a flexible fiber optic bronchoscope, that is an optical bronchoscope, and the right side is a flexible fiber optic bronchoscope which attached with a display in it. So, in the left side, only the practitioner can able to see the lung parenchyma, whereas in right side of my image, it shows a display connected in that, whereas the lung the tip enters into the lung parenchyma, it will be displayed in the pictures. This image shows the practitioner is using a flexible fiber optic bronchoscopy, and it further moves into the left main bronchus. So only the practitioner can able to see where the bronchoscope tube is inserted and it is placed. In this image, you can able to see the practitioner inserting a bronchoscope into the patient's airway. Not only the practitioner can able to see the lung parenchyma, along with the nurses, respiratory therapists, everyone can able to see the lung parenchyma, what is there. The tube is inserted whether in it is in a left main bronchus or right main bronchus, or further divided into the bronchis, or everything will be seen in the display. Okay, now we come to users. Diagnostic purpose. Diagnostic evaluations of symptoms like a persistent cough, hemoptysis, or abdominal chest x-rays, biopsies of lung masses, lymph nodes, or other lesions, collection of a sample for culture in cases of suspected infections, removal of foreign bodies or obstructions, treatment of airway stenosis, tumor or other growth, management of hemoptysis. When it comes to cough, the persistent cough without hemoptysis in a well patient with a chest radiographic features that are either normal or unsuggestive of neoplasm. Abnormal chest radiograph. The chest radiograph shows an opacity consist with a lung tumor or changes suggestive of bronchial obstruction, such as appearance of yearly volume loss or undoubted collapse. The unresolved pneumonia or hemidiaphragmatic paralysis raises the possibility of phrenic nerve involvement. Positive sputum cytology. The expectorated sputum may contain a neoplastic cells on a cytological examination, even though the chest radiograph itself provides no clear localizing features. Identification of infective agents. So bronchoscope may be used to obtain a microbiological evidence of lower respiratory tract infection by taking a biopsy for suspected malignancy or interstitial lung disease, culture for infections like tuberculosis. These will be taken by aspirated bronchial secretions, bronchial wash or bronchoalveolar lavage, endobronchial brushings, tracheobronchial lung biopsy. First, we will be seeing a bronchoalveolar lavage. A large volume of 100 to 150 ml of sterile saline is instilled into the specific bronchial segments, typically within the middle or lower lobe. The fluid is aspirated and collected in a sterile containers, so provides a sample for a distal airway and alveoli. So most common applications will be diagnosis for interstitial lung disease, alveolar hemorrhage. Bronchoalveolar lavage. In this image, you can able to see the bronchoscope is connected with a mucus extractor, where the normal saline is instilled into the patient's airway and is aspirated, and it will be collected in the mucus extractor, and it will be given for a sample testing. Now, the second one is the endobronchial biopsy. The forceps are passed through the working channel of the bronchoscope to obtain a tissue sample from visible endobronchial lesions. So, diagnosis of a lung cancer, sarcoidosis or other airway pathologies. So, common application will be histological examination for malignancy or granulomatous diseases. You can able to see the bronchoscope is inserted in the larger airways, and is also from the working channel the forceps is inserted. The forceps takes some tissue particles from the lung parenchyma for an examination purpose. Next, the third one is a brush cytology. A cytology brush is passed through the bronchoscope to scrap cells from the bronchial mucosa or lesions. So, common applications will be diagnosis of malignancy or infections like a candida or aspergillus. In this image, you can able to see the bronchoscope inserted in the working channel. The bronchial brush, that is a cytology brush, has been inserted through the smaller airways, and it's being brushed in the lung parenchyma. So, it been brushed in the lung parenchyma and take out the particles, and it will be given for a cytological purpose. Uses. The therapeutic purpose: insertion of an endobronchial tube for general anesthesia in patients with whom extension of a neck may be dangerous. Removal of a foreign body. This method is more convenient because the patients only need to be lightly sedated. flexible bronchoscope can reach narrower bronchi than the rigid bronchoscope. However, a rigid bronchoscope is generally considered to be better for removing larger foreign bodies. In some cases, a combination of bronchoscopy and other techniques may be used to remove a foreign body obstructions. So, that is electromagnet or cryotherapy. These techniques can be used to cut or destroy granulation tissue that may have grown around the foreign objects, or baskets or cryogenic probes. These devices can help with the diagnosis and dislodging foreign objects. In a procedure, before going to the procedure, first we will be setting up a patient preparation. So, fasting NPO status. So, patient should fast for 6 to 8 hours before the procedure. Prevents aspiration during or after the procedure, especially under sedation or anesthesia. Explain the procedure in clear, simple terms, including its purpose, process and potential risk and benefits. So, obtain a signed consent ensuring the patient is fully understand the procedure. Evaluate the patient's medical history, current medications and allergies to determine patient sedation needs. In a local anesthesia, the 4% lignocaine solution sprayed via atomizer into the patient's mouth in direction of the fauces. Ask the patient to say to evaluate the soft palate, and administer sedatives like midazolam and injection morphine for an reduce anxiety or suppress coughing. And in monitoring purpose, so continuous monitoring starts baseline monitoring and continues throughout the procedure, including pulse oximeter, ECG, blood pressure and supplemental oxygen. So, administer if necessary to maintain oxygen level saturation. And check for a functional check of equipment. So, check the bending mechanics and lens clarity and insertion tube integrity of a bronchoscope. Test for adequate brightness and ensure the connection is secure in the light sources. Verify that the suction system is operational and adjust settings to the appropriate level. So, inspect forceps, needles or brushes for functionality. Ensure the availability of oxygen supply, ambu bag and defibrillator in emergency system. Next, bronchoscope should be lubricated with a 2% lignocaine gel and advance the bronchoscope via either nostrils or mouth using a bite blocker. So, in this image you can able to see the patient is placed on a table. The operator stands behind the patient at the head end. The practitioner is seeing the monitor where the bronchoscope is inserted and the procedure further till ends. Advancing the instrument and observation. Visualization of epiglottitis and larynx. As the instrument is advanced, the epiglottitis and the larynx become visible. Carefully observe these structures for any abnormalities or obstruction. So, note the opposition and the movement of the vocal cord with respiration. Ask the patient to say E to observe the full opposition of the cords during vocalization. Once the vocal cord are visualized and assessed, carefully advance the instrument through the glottic openings and then administer 2.5 ml of lignocaine followed by a 5 ml of air to reduce the discomfort and suppress the cough reflex. After passing behind the vocal cord, inspect the following site: trachea, main carina, subcarina and segmental bronchi. So, in a carina, observe the normal anatomy and signs of pathology, that is an example of infections or any stenosis or any some abnormal growths, and examine the bifurcation of a trachea into the left and right main bronchus. Ensure this region is also clear and free from abnormalities. Now, we will be seeing a complication. The first one will be a common minor complications due to irritations from the bronchoscope. The patient may get a sore throat or hoarseness. So, cough or bronchospasm caused by airway irritations during the procedure. The nasal bleed. Nasal bleed is more common if the bronchoscope is inserted through the nose. The second one will be a respiratory complication. Decreased oxygen level can occur during the procedure, especially if airway blockage or prolonged bronchoscope insertion occurs. Temporary obstruction can be caused by bronchoscope tube or secretions. Bronchoscopy, the narrowing of the airway due to irritations, more common in patients with asthma or reactive airway diseases. Pneumothorax, rare but possible during procedure involving biopsy or tracheobronchial interventions leading to a lung collapse. So, pulmonary hemorrhage, the bleeding can result from biopsies, brushings or forceful intervention. In the third one, we can able to see that cardiovascular complications, the arrhythmias, changes in heart rhythm may occur particularly in patients with underlying heart conditions. So, drop in blood pressure often due to sedation or vagal stimulation. Hypertension patient having a stress or discomfort during the procedure may cause a transient elevation of pressure. The contraindications like uncooperative patients, uncorrectable hypoxemia or hypercapnia, unstable myocardium, uncorrectable bleeding tendency, transient stenosis and poorly controlled asthma, or these are the patients who have been excluded in a bronchoscopy procedure. In summary, we have been seen a bronchoscopy, visualizing airway using a rigid or flexible bronchoscope for diagnostic and therapeutic purpose, a rigid bronchoscope for a larger obstruction or bleeding and tumors, flexible bronchoscope for bronchoscopies, lavage, and it may extend into a smaller airways. So, indications such as cough, hemoptysis, abnormal imaging, obstructions and infection. Procedures like getting a consent, making a patient in a NPO, sedation, anesthesia, airway inspection, sample collection will be involved. So, complications such as pneumothorax, bleeding, hypoxemia, sedation issues. Contraindications like severe hypoxemia, tracheal stenosis, unstable conditions. Whereas in infection control, sterilization, PPE, in infection control, sterilization of a bronchoscopy in a pre and post procedure is mandatory. Personal protective equipments for a patient and the practitioner should be provided. So, in conclusion, would be a safe and effective requirement of an expertise. So, these are my references. Thank you.